Hey everyone, and welcome to the CPC chapter review for radiology. I'm Victoria Moll. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe, hit the notification bell so you can get alerts when I post new episodes. So this is part of the series that I have been doing on reviewing different sections of medical coding that kind of correlate with the CPC curriculum. So we're going to go over a little bit of radiology today, talk about what's entailed in the radiology chapter, more so in CPT, and then we're going to do a couple of practice questions. So let's start out looking at the CPT section for radiology. We're actually not going to go over too much ICD-10-CM because there could be so many different sections that are applicable to radiology, but we can go over some CPT. So it starts out in the radiology section of CPT with our diagnostic radiology and diagnostic imaging. And we start with the head and the neck. Now, we talked a little bit in the past about how when CPT orders their codes, they usually go with the head and then down to the toe. So they'll start with procedures of the head, procedures of the neck, procedures of the shoulders, procedures of the upper extremities, trunk, etc. But they kind of are all over the place with radiology. So it starts with the head and the neck. And that includes not just things like your jaw, but also imaging of your sinuses and imagings of like CT scans of the brain. We have chest, spine, and pelvis, and that includes things like the bending views that they do to diagnose scoliosis, and then upper extremities, lower extremities, abdomen, GI tract, urinary tract, gynecological and obstetrical, and heart. And then we have our vascular procedures after that, so special sections for vascular procedures of the aorta and arteries, veins and lymphatics, so our lymphangiographies, our shuntograms, our venographies, and then transcatheter procedures, and then other procedures of the vascular system. Then we have diagnostic ultrasounds, so head and neck, chest, abdomen, and retroperitoneum, and then spinal canal. Under the pelvis, we have our obstetrical and non-obstetrical, so our pregnant patients and our non-pregnant patients. Genitalia, extremities, ultrasonic guidance procedures, so things like needle placements or amniocentesis. And then we have our other procedures, radiological guidance of fluoroscopic guidance, CT guidance, MRIs, breast mammography, bone and joint studies, and radiation oncology. Then we have consultation, clinical management, clinical treatment planning, and those are broken down between simple, intermediate, and complex. So definitely check out those CPT definitions in your book of the simple versus the intermediate versus the complex in that section. We have medical radiation physics, dosimetry, treatment devices and special services, stereotactic radiation treatment delivery, other procedures, radiation treatment delivery, neuron beam treatment delivery, radiation treatment management, proton beam treatment delivery, hyperthermia, clinical intracavitary hyperthermia, clinical brachytherapy, and then we have our nuclear medicine diagnostic section. So endocrine, hematopoietic, reticuloendothelial and lymphatic systems, GI, musculocardio, respiratory, nervous, GU, other procedures, and then at the very, very end is our therapeutic. So radiology is not a large section. It's not super complicated, but there are definitely some nuances to it. For example, in ICD-10-CM, when we know the definitive diagnosis, we can code the definitive diagnosis, but a lot of times in radiology, we don't know that definitive diagnosis. Typically, we're just ordering it, the provider's ordering it based off of the signs or symptoms. So, if a patient's coming in and they have wrist pain, they're going to order a wrist x-ray. And if that's all we have at the time of that order, we will code for that wrist pain. However, if the interpreting physician already read the film and they've having that definitive diagnosis and they're saying, oh, it's a wrist fracture, then we're going to report the fracture. But if all we have to go on is just that order where they're saying it's a wrist pain, then we would code for the wrist pain for the order. So it's important to remember, in physician coding, we don't code questionable diagnoses. So if the provider says questionable wrist fracture or possible wrist fracture, we can't code that as a wrist fracture in professional fee coding. If the patient is getting a routine x-ray without any specific symptom or diagnosis, the diagnosis code then reported would be Z01.89, which is encountered for other specified special examination. The three planes that are most commonly used in anatomical and medical imaging are the sagittal, the frontal or coronal, and the transverse plane. So for radiology, you need to study things like your directions and terms like proximal. So proximal meaning closer to the point of attachment to the body, or distal meaning away from a point of attachment from the body. Some of the top concepts we have are things like S&I, or supervision and interpretation. So when a procedure requires radiologic guidance, a code from the surgery or medicine section is reported along with the supervision and interpretation code from the radiology section. But when the physician provides both that surgical component and they're providing that radiological guidance, so they're doing both, they're acting as surgeon and radiologist, that physician is going to report both of those codes. But when the physician is performing the surgery and another physician is reporting radiology, surgeon is going to report surgery codes, radiologist is going to report the radiology codes. So the radiologist performs the supervision and interpretation and is going to report those appropriate codes for their services. Contrast material. So contrast material is a substance or material that lights up when it's being studied so that we can visualize it, right? And sometimes it's done orally or rectally, but that doesn't qualify for a code done with contrast. So when they're saying in contrast, they're not talking about the oral or the rectal contrast. They're talking about more like our IV or intrathecal contrast. So keep in mind that the supply, though, of that contrast material is not included. So we could build that out with a HCPCS code. And another important thing is our TC and 26 modifiers. So TC is your technical component. 26 is the provider interpretation or professional component. So if you think about TC technical component, the technical component is that use of the equipment. So in the event of, let's go back to our kind of wrist x-ray. If we're x-raying the wrist, the provider does an x-ray of the wrist, there's that technical component involved in that, which is actually using that x-ray machine. And the use of the machine, the equipment, is the technical component. 26 is that provider actually pulling up that x-ray and going, yep, that's a fracture, and providing their professional interpretation of that and writing that down into the documentation. In some cases, they may do both. We see this a lot in like urgent care settings. The provider is going to do an ultrasound and they're also going to interpret it. You may see this in cardiology or in urgent cares. They own that equipment. They're using that equipment. They're also doing the professional interpretation of that image. So you have to be very careful with those TC and 26 modifiers. Some CPT codes do inherently say professional component only. We have some nuances in our 90,000 series that we'll talk about with things like EKGs. Sometimes they have one that's a bundled code with the professional and technical, and then they have one that's technical, and then they have one that's just professional. So you really have to pay attention to the description of that CPT code, and then if it already says professional component, you don't need to put on the professional component modifier to that as well. So many of the x-ray codes talk about the number of views, so they might say it's 2 views, 3 views, or it might say something like a minimum of 2 views, in which case if you do 2 views, 3 views, 4 views, that's at least a minimum of 2. If you do 1, that's not a minimum of 2. So pay attention to that number of views because that needs to be taken in consideration for the code selection. So for example, there's a code for the radiological examination of the mandible and it says minimum of 4 views. So if we do 5 views, we still use that code. We've hit that minimum of at least 4, and we're not going to code something extra for that. There's no additional code for the additional views that are being taken. Now let's do a couple of practice questions. Provider orders an ultrasound of the liver for cystic disease of the liver. We have A 76700, B 74022, C is 76705, and D is 74044. So here's our radiology section. This is our radiology. Here is our diagnostic ultrasounds. So where is this located? It's in the liver, right? So yeah, ultrasound of the liver, diagnostic ultrasound, and we are in the abdomen and retroperitoneum area. That's where your liver would be located. So page 536. So 536, abdomen and retroperitoneum. Let's flip it over to the other side. And we have, let's zoom in. So here we have ultrasound abdominal real-time with image documentation complete. And then we have limited, so single organ. And that's what we did. We didn't do the whole abdomen. We just did a single organ. We were just looking at the liver. So 76705 would be the correct code, because this one is the full abdomen. We didn't look at the full abdomen. We just did the liver. 74002 doesn't sound like it's in the right section. 74002 doesn't sound like it's in the right section, and neither does 74044. So in this case, our correct code would be 76700. So because this is not the full complete, we're just going to code it to the limited of the abdomen. Ultrasound abdominal real-time with image documentation, limited single organ quadrant follow-up. So in this case, the patient presents to urgent care after falling from a bicycle. Patient has open wounds and severe pain in the right lower leg, and the provider orders a 2-view x-ray. So let's go back to our book. So this one wasn't an ultrasound, it was a diagnostic image. So we're trying to diagnose what's going on with this patient's lower extremity, right? Because it says they fell from their bicycle and injured their right lower leg. So we're going to be here on page 522. That's where that's going to start. Now right away I'm seeing this ankle code, but this I don't think says ankle. It just says lower leg. So here we are, pelvis, probably going to go to hip, femur. No, this is where our medical terminology comes in. Where's the femur? Is that the upper leg or the lower leg? So the femur is your big, thick thigh bone. So the femur wouldn't be that, because this says it's the right lower leg. So lower leg, remember what the bones of the lower leg are? They are the tibia and fibula. And we did 2 views here, right? Was this an infant? We're going to assume it's not an infant. It doesn't say it's an infant. So radiological examination, tibia and fibula, 2 views, and that's what we have here. Right lower leg, and we have a 2 view. And that looks like it's our right code, tibia and fibula, 2 view, 73590. Of course, it's going to have the RT modifier. It was done on the right side. So is that one of our options? Yep, that is our option C. So 73590 with an RT modifier. And this is our last question, superior sagittal sinus venography, radiological supervision and interpretation for megalencephaly. When we look at these answers here, look, these 2 are the same, and these 2 are the same. So we could look these up in our ICD-10-CM, and we could eliminate half of the questions just by getting the right code for the diagnosis correct. And then it looks like this and this are the same as well. So that's kind of leading me to believe it's going to be either B or D, because they're probably testing, do I know that it's this code with this diagnosis? But let's take a look. So superior sagittal sinus venography, radiological supervision and interpretation for megalencephaly. So if we peek at our ICD-10-CM manual, we can see here megalencephaly is Q04.5. So that means it's either A or B. We can right away eliminate our options C and D. And then we just need to know if it's 75870 or 75827. I told you I'm already kind of leaning towards that option B there, right? So we talked about how here under the vascular procedures for vein and lymphatics would be where our venography codes are. So this is superior sagittal sinus venography. We're going to probably be in these codes right here in this range. And it looks like both of them are within that range. So page 530. So here we have venography, caval, superior, and seriography. Radiological supervision and interpretation is the 27 code. That doesn't sound like what we did here. We did the superior sagittal sinus. And what does our 870 say? So our 870 is venography, superior sagittal, there we go, superior sagittal sinus, radiological supervision and interpretation. And that's what we have here. We have superior sagittal sinus venography, radiological supervision, and interpretation, which means that that is our option B. 75870 and Q05.4. I hope you found this video helpful. Again, there's lots of other great CPC review videos. If you go to the main channel page and check on the playlist, you can binge watch the entire CPC review. I will see you guys in the next video, and until then, just keep on coding on.